Hi, everybody. Welcome back from your break. My name is Dr. Christine Walsh, and I'll be talking to you about sleep. And I want to thank you all for coming to join us today, and especially for coming back from the break to actually listen to talk about sleep. And we'll see how sleepy you all are by the end. So I'm based at the University of California, San Francisco, in the Memory and Aging Center there. And today's talk will be focused on a brief look at the typical effects of sleep loss, sleep and precursors to an unhealthy brain, general health can alter sleep, comment about sleep disorders, sleep and neurodegenerative diseases, both an overview and a short comment about MSA, PSP, and corticobasal syndrome, an ongoing remote clinical trial for sleep and PSP that we're running through UCSF. And then at my ending comments, I'll do a brief piece about sleep hygiene or general sleep health. So what is the ideal duration of sleep? This is one of the most common asked questions. And the overall guideline from the American Academy of Sleep Medicine is 7.5 hours. But of course, the real answer is it's the right amount for you. So that means that you are awake, alert, and energetic throughout the day. And a lack of sleep can cause increased sensitivity to pain, a suppressed immune system, temperature dysregulation. So this is where if you've been awake all night the night before, you might find that you go through runs of being really hot and then really cold. And it's just really hard to regulate your temperature. You become hungry, but for less healthy foods. So when you are well rested, you'll go towards the more rainbow colored foods, so the healthier vegetables and fruit. And when you're sleepier or sleep deprived, you tend towards the high carb, high fatty foods. So the chocolate, the potato crisps, the pizza, all the unhealthy foods. And unfortunately, pairing with this, this push towards less healthy foods, sleep disruption causes dysregulation of both your insulin and ghrelin. So these are two hormones and neuropeptides that are associated with obesity and metabolic disease. So both what you're eating and also how your body is actually functioning internally are both affecting how you can actually metabolize food and long-term effects towards diabetes and things like that. Lack of sleep also affects how well we can regulate our own emotions, but also to read other people's emotions. So for example, there's a loss of emotional regulation and awareness where people can see the extremes on someone's face, but they have a much harder time realizing how someone is feeling based on the more intermediate expressions of mood. There's increased risk-taking with sleep loss and poor judgment. And so this is where there's an increased number of car accidents associated with sleep loss because someone is judging whether or not they can make it through that orange light before it turns red. Our social skills become impaired. So it's harder to bargain. People become less trusting. And of course, in the caregiving patient partnership, this can be really impactful in someone's ability to really navigate someone's health best. And of course, cognition can also become impaired with sleep. And we've all had those days where it's really hard to find the right words, or it feels like our brain's in quicksand, trying to just trudge forward and get each thought to actually connect together. And 14 days of 6 hours of sleep at night is equivalent to about 2 days of complete sleep deprivation when assessing a reaction time task. So that's pretty significant when we each think about how much sleep we're actually getting each night. And there's an old myth that older adults do not need as much sleep as young adults, and that's completely wrong. We need roughly the same amount of sleep through our entire adulthood. And some of the research that's been done with people collaborating with me, so with some of our students, is that longer time spent in REM sleep was associated with healthier white matter in the corpus callosum. And the corpus callosum are these big white matter tracts, so like the phone wires connecting the different hemispheres of the brain together. So that helps to send signals quickly to different sections of our brain, so the communication. And we also found that symptoms of insomnia, even minor symptoms of insomnia, so below the level of a clinical diagnosis of insomnia, are associated with smaller cortical thickness. So that's where the actual hemispheres are slightly shrunken in specific areas that are often associated as precursors to neurodegenerative disease. And the types of sleep disruption can affect different parts of the brain differently, can affect functional processes differently, and even can affect a diagnosis of mild cognitive impairment, where in one study, if someone slept well the night before, they had a diagnosis of cognitively healthy, and if they slept poorly the night before, they received a diagnosis of mild cognitive impairment. And they tracked these individuals on a daily basis, both cognitively and looking at their sleep the night before across a month. And this is the pattern that they saw. So I've mentioned about sleep disruption and brain health, but what do we think is actually behind some of this? So there have been a number of studies now trying to actually look at the proteins that are affecting our brain or in our brain and how they're affected in sleep deprivation. And so in a mouse model that is specifically prone to phosphorylated tau, which occurs in the tauopathies such as Alzheimer's disease, progressive supranuclear palsy, and corticobasal degeneration, in those animals that were chronically sleep deprived, so they were allowed sleep, but they were restricted in how much sleep they were allowed to get, versus those that were allowed to sleep normally, they had increased phosphorylated tau occurring. So these black dots, we don't want those. And they found similar results for alpha-synuclein, which we think a lot about for multiple systems atrophy. And we also have similar findings in amyloid beta, so in the protein often associated with Alzheimer's disease. So other factors that alter sleep and neurodegenerative diseases, there's physiological changes. So weight change can really affect how someone's able to sleep. The occurrence of other sleep disorders, which I'll come to in a moment. Medical and psychiatric morbidity. So for this, I'm mentioning hypertension, congestive heart failure, diabetes, depression. These can all affect how someone's actually able to sleep. Medication side effects often affect our sleep, and environmental and behavioral factors. So are you sleeping in a hot or a cold room? Are you a caregiver? Do you have a pet that often is jumping onto your bed? Things like that can really affect how well your sleep is. So sleep disorders. Sleep apnea is a very commonly spoken about one, and it occurs in at least 45 to 62% of the population. Some signs and symptoms include loud snoring, breathing interruptions while sleeping, excessive daytime sleepiness. So this is, you feel very sleepy, fatigued, your somnolence is another word for sleeping during the day. You wake up with a dry mouth and a morning headache. And sometimes people hear loud snoring and automatically think that that is sleep apnea, and it may be, but you can normally actually hear someone holding their breath, and it's kind of that type of sound, especially the at the end. So if you hear that, it's very likely that someone has sleep apnea. Possible increased likelihood of hypertension, stroke, ischemic heart disease, and increased arteriosclerosis. But it could contribute to reversible dementia in older adults and could also help alleviate some of the global symptoms or cognitive deficits associated with some neurodegenerative diseases. It will not necessarily reverse that, but it could improve it a bit. And so there are several treatments. It's not always just CPAP. And if it is, there's a new mask coming out typically every June. So keep an eye out for those and do follow up. And it's really important if you do have sleep apnea to really stick with that treatment, especially for the first 2 weeks. It shows the most likelihood that you will continue and do well with those treatments. You may have heard about periodic limb movements or PLMs. or restless leg syndrome, RLS. And those are two very different diseases or sleep disorders. Periodic limbs may be in approximately 45% of older adults, and this is a limb movement during deeper stages of sleep. So this is not when you're initially falling asleep and you get a sudden jerk. This is more when you're further into sleep and you'll have periodic movements. And so you can have them as many as 3 times in 90 seconds. So once every 30 seconds, and then you'll go quiet for a while. In contrast, restless leg syndrome does have a higher presentation in women, occurs in about 10 to 35% of older adults, often is most seen prior to bedtime, and it's eased with moving around. So it doesn't necessarily wake someone up, but it is eased with movement prior to bed. Or leg massage can help as well. REM sleep behavior disorder is acting out dreams. And 9 out of 10 patients with REM behavioral disorder are thought to be men. This number is now changing because they're realizing that women present just slightly differently, but it still is thought to occur more in men. Ways to reduce or protect against REM behavioral disorder is to do a medication review. So acting out dreams, again, this is not referring to the initial jerk that you get shortly after you fall asleep when you think you're either slipping on something or falling off a cliff. This is actually a full acting out of a dream. And it's when someone wakes up or you wake someone up and you say, what were you dreaming about? And the actions actually match that of the actions that you saw. So the dream and the actions match. In women, you may see more jaw clenching, and you can tell sometimes by the type of dreams being reported for women. Neurodegenerative disease and sleep in humans. So the sleep issues that occur in different neurodegenerative diseases can be very different. So for example, in Alzheimer's disease, there's sundowning. This is where people become more awake and alert and agitated as the sun is going down, so in the evening. Sleep respiratory disorders, such as sleep apnea that I just mentioned. There's a change in their sleep architecture, so the type of sleep they're getting changes, and when they're most active and least active, or their circadian phase changes. With frontotemporal dementia, there's a change in their sleep-wake rhythm, circadian phase changes. I'll be talking about progressive supranuclear palsy and corticobasal degeneration in a minute. In Parkinson's disease, you do see increased likelihood of REM sleep behavioral disorder, increased insomnia, restless leg syndrome, and excessive daytime sleepiness. So this is where someone's falling asleep a lot during the day. And in Huntington's disease, we see a lot of insomnia, changes in sleep architecture, again, REM sleep behavior disorder, and now periodic limb movements. I'll be talking about multiple systems atrophy right now. So in MSA, in the prodromal MSA form, it's thought that REM sleep behavioral disorder, or RBD, occurs in approximately 88% of individuals. There's also stridor, which is another type of a breathing disruption, occurs during sleep. And there are thought to be insomnia symptoms. Once MSA is fully formed and diagnosed, we still see RBD, so this REM sleep behavioral disorder. Stridor occurs in approximately 40% of individuals. We see increased periodic limb movements, increased insomnia, and in particular, difficulty remaining asleep. So this is once someone's fallen asleep, they have large periods of wake after that initial sleep onset. We do see excessive daytime sleepiness in about 25% of individuals, and fatigue. So fatigue is a little bit different to sleepiness, where fatigue is it's just hard to get up and do something. Hard movements feel very, very draining. So it's not that you're actually falling asleep, but that you feel very drained of energy. And there's altered circadian rhythms. With REM sleep behavior disorder being so prominent in MSA, and it may be the most prominent neurodegenerative disease that REM sleep behavior disorder is occurring in, it does occur prior to disease onset, as mentioned in the prodromal MSA. The features of REM sleep behavioral disorder are similar across the MSA subgroups, so could not necessarily predict which of the future MSA groups you will fall into. But what is interesting is that the RBD versus wakefulness activity, people do see better movements, better facial expression, and better speech patterns occurring in the REM behavioral dream enactment as opposed to what's achievable during wakefulness. And so that suggests that during sleep, specific functional pathways in MSA are lifted or released that are being dampened down during wake. And so this is an area that people are trying to better understand to see, is there a way of untapping some of those remaining functional pathways during wake that are being unmasked during REM sleep behavioral disorder. And of course, our brains are very similar. The activity and the neurochemical milieu that's floating around in our brain is similar between wake and REM sleep. And so that's why there is the hope that that unmasking could occur. Next, I'll be talking about progressive supranuclear palsy. And so this is the neurodegenerative disease that I've been most focused on during my career so far. And one of the reasons for that, if we look at the progression of progressive supranuclear palsy, those areas that are earliest affected in the disease overlap with the nuclei that help regulate sleep and wake. And based on your neurodegenerative disease patterns, we hypothesized that sleep disruption would not be generalizable across 4R tauopathies. So in other words, that there would be different sleep patterns across progressive supranuclear palsy and corticobasal syndrome, in particular in comparison to controls. So we hypothesized that sleep would be more disrupted in PSP as compared to corticobasal syndrome and controls, and also that sleep would be polyphasic in PSP, so that it would occur in bouts throughout the 24-hour period with increased daytime somnolence. So we expected increased daytime sleepiness with shortened periods to fall asleep during nap opportunities and disrupted rest activity rhythms. So in an earlier paper that we published, looking on the left, we have two examples of healthy older adults where the bright green is their activity during the day. In the middle of these graphs is midnight, so you can clearly see periods of inactivity. So this is when these participants were in bed asleep. And in the right, we have two samples of PSP participants. And this activity was measured by using a wristwatch that specifically measures actigraphy. This is a research grade watch. It's not a Fitbit, but similar idea. And you can see in comparison to the healthy older adults that the pattern in PSP is there's no clear bedtime period in this individual. It's kind of drifting, and we have this S-shaped pattern occurring. And then in this individual, we see more activity, little spikes of activity during the night. And so overall, we found weaker rest activity rhythms in PSP after controlling for sleep fragmentation, cognitive impairment, and depression. And then we were looking at sleep, and tools that we use for measuring sleep is we bring people into a sleep lab or a hotel, and we put a series of wires or electrodes on their face and on their head and on their torso. But we also do at-home sleep assessments, and this is the main way that we're assessing sleep the past couple of years, and we'll be continuing to do this. So we have a lightweight device that sits across someone's forehead, and they wear that for 3 individual nights. And then we also do an assessment for sleep apnea on a separate night. And using both the in-lab assessments and the at-home sleep assessments, we can look for how long it takes someone to fall asleep. So how long were they awake before they initially fell asleep? How long were they in light sleep, deep sleep, or non-REM 3 sleep, and REM sleep? And how much of the night were they awake? So what was their wake after sleep onset like? So looking at the presence of sleep disorders, we found that overall there was a slight increase in sleep apnea in those with PSP as compared to corticobasal syndrome and controls, that this was not statistically significant. We did find a large increase in the existence of periodic limb movements in PSP as compared to those with corticobasal syndrome and controls. And we also found an increase in the arousal index. This is brief awakening, so it's shorter than a full awakening, but essentially people are briefly waking up or arousing their brains to a level of wake. So that was greater in PSP as compared to the other two groups. When we look at how long in green it took someone to fall asleep, how long someone spent asleep in navy, and how long somebody was awake after initially falling asleep in the bright orange, we see for controls, PSPs, and corticobasal syndrome, that PSPs took significantly longer to fall asleep as compared to controls and corticobasal syndrome. That PSPs spent less time asleep in comparison to controls and corticobasal syndrome, and they had a greater amount of time spent awake after initially falling asleep. In contrast, though, the sleep seen in corticobasal syndrome was very similar to that of controls. So they had similar amounts of sleep during the night. A slightly complicated graph, but essentially we're looking at percentages for non-REM 1, non-REM 2, non-REM 3 sleep, so the different stages of sleep, so lighter sleep, deep sleep, REM sleep, and wake after initially falling asleep or wake after sleep onset. In blue, we have controls. In red, we have PSP. And in green, we have corticobasal syndrome. And the main take home is that you can see that in red, the PSPs, they're skewed to the left with greater wake, less time in non-REM stages 2, 3, and less time in REM sleep as compared to controls. And that overall, corticobasal syndrome is fairly similar to controls at each of the sleep stages. When we looked at someone's likelihood of falling asleep when given nap opportunities, so for this assessment, we gave people 5 periods, timed periods throughout the day, where they were in a dark room, no stimulus, no talking, and we gave them 20 minutes to see if they would fall asleep. And what we found is, when we look at blue for controls, red for PSP, and green for those with corticobasal syndrome, whether they are amyloid positive in triangle or negative in the star, the higher on the y-axis, the more awake they were, or they never fell asleep if they were up at 20, whereas the lower on the y-axis, the faster they fell asleep during these nap opportunities. And you can see that PSP took longer to fall asleep during these nap opportunities during the day as compared to controls and corticobasal syndrome. And in some of our individuals, overall, looking at subcohort, we see that those that fell asleep, PSPs had on average roughly 5 hours of sleep, and it took them approximately 17 minutes to fall asleep during the nap opportunities the next day. In comparison to corticobasal syndrome with nearly 6 hours of sleep, it took them just shy of 10 minutes to fall asleep. And this was faster even than compared to controls. So with little sleep at night, some PSPs did not nap at all. So we had one individual with 2.5 hours of sleep, another one with 3 hours, 20 minutes, and someone with 4 hours and 18 minutes. And across those, they never fell asleep. We did have one individual with corticobasal syndrome who did not sleep during the day. And it's unclear to us, but we hypothesize that this individual does have underlying PSP as their root of disease. To summarize, we found that PSP had disrupted sleep-wake regulation with a decreased ability to sleep during the day or night. they had disrupted REM sleep regulation and a marked decreased homeostatic sleep drive. So what that means is if we think about our sleep pressure builds across the day, and then nighttime comes and we should fall asleep. And that would be the homeostatic pattern of sleep-wake cycles. However, what we think is happening essentially in PSP is that the sensitivity to this homeostatic sleep drive is not occurring, and we have a continuation of a drive to remain awake. And I'll come back to that in one moment. In contrast, we have our corticobasal syndrome cohort, where we found increased daytime somnolence with the possible increased homeostatic sleep drive. So this would suggest that they have more difficulty remaining awake during the daytime periods. So they have more pressure to try to sleep. We did do another study, a pilot study, where we looked at individuals who slept during the night or had difficulty sleeping during the night. And again, instead of asking them to try to nap during the day, instead we asked them to try to remain awake during the day. And again, we put them into low stimulus environments, and similar to the story I just told you, those with PSP remained awake, while those with corticobasal syndrome had trouble remaining awake during the day. And as I mentioned earlier, we have different nuclei within the brainstem area or within the brain that are either pushing for us to remain awake or pushing for us to be asleep. And this is called the sleep flip-flop switch. And our work with our collaborators has found that wake-promoting nuclei are relatively preserved in PSP and corticobasal degeneration compared to Alzheimer's disease. However, in this sample, we did not have any clinical sleep measurements. So we wanted to look at how sleep during life was associated with neuronal counts, or how those neurons were affected during the autopsy assessments. So this is a paper just recently accepted into JAMA Neurology, and we were very lucky. It received a lot of publicity, so you may have already heard about some of this. But to just quickly recap it, so our hypothesis was that the number of subcortical wake-promoting neurons, so the neurons pushing to be awake, would correlate with sleep duration and sleep fragmentation. And our goal was to gain insight to the neuronal basis of sleep in the human brain and begin to identify potential targeted treatments. So in this study, we had 18 clinical sleep controls and 20 progressive supranuclear palsy patients who underwent polysomnography. And we had 14 clinical sleep controls and 33 Alzheimer's disease participants who underwent EEG. Of those that took part in our studies, 19 went on for postmortem analysis, 9 had PSP, and 10 had Alzheimer's disease. And we looked specifically at those wake-promoting neurons. As expected, Alzheimer's disease had a greater sleep drive, so they slept more, they had less wake during the night, and better sleep maintenance, and fewer total neurons within the wake-promoting nuclei. And when we ran correlations, we found that across the neurons that we were specifically looking at, that we did find that those wake-promoting neurons were associated with the loss of sleep drive and with increased sleep fragmentation. And so we also used unbiased approaches using statistical analysis called K-means cluster and PCA analysis, and we found the exact same results. So we found a greater number of wake-promoting neurons were associated with decreased sleep drive, and that the greater locus coeruleus neurons, another one type of neuron within those wake-promoting neurons, was associated with less sleep and longer REM latencies. And that the PSP predominant group had decreased sleep drive associated with the relative sparing of wake-promoting neurons, suggesting that the number of subcortical wake-promoting neurons relates to sleep phenotypes, and that tau accumulation is sufficient to disrupt sleep-wake balances. So between this study and our previous work on other pathological assessments and our clinical sleep assessments, we developed a clinical trial assessing medications targeting both sleep and wake systems. So this is a fully remote study with no in-person visit, and it's specifically for individuals with PSP. It's a 6-week crossover design, meaning everybody gets each of the study medications and the placebo. It's using 2 FDA-approved hypnotics or sleep medications. The first is zolpidem, which is an agonist, which is turning on the sleep-regulating system. And the other is suvorexant, which is an orexin or wake-promoting neuron antagonist. So it's turning off wake. So we have one medication to turn sleep on and comparing it to the sleep medication that's turning wake off. And again, we found that the wake on neurons are basically running unchecked or are more preserved in PSP. And that's why we hypothesize that suvorexant will be more effective in treating sleep issues in PSP. So we have a series of at-home sleep assessments where we send this device to measure sleep, and we also send the wristwatch to measure activity. We have a patient caregiver report where they complete a few sentences about the primary participant, comment about the primary participant's alertness and sleepiness, and a clinician assesses overall well-being using global impression changes. So how is the participant doing globally in their general functioning, and how's their quality of life? And our goals or aims are to examine the efficacy and safety of suvorexant and zolpidem in PSP, and to test the acceptability and feasibility of conducting a fully remote randomized clinical trial where nobody has to go into a primary research center. So we're trying to improve accessibility for anyone interested in participating in the study. And so far, we are at the relative beginning of the study, but we have been fairly good since we're operating through UCSF. We have had participants as far as Alaska and Maine. The future goals of our team at UCSF is to better understand how sleep is affected in PSP, corticobasal syndrome, and MSA, with an ongoing remote at-home observational study. We're working towards sleep-wake interventions in corticobasal syndrome and MSA, and we're continuing recruitment for our remote clinical sleep trial in PSP. A brief mention about good sleep hygiene. So the best additional ways to try to help manage sleep issues are to maintain regular bedtime and rise times throughout the week, to limit time in bed to sleeping, to avoid or reduce napping, and when napping, to make sure it's completed before 3 p.m. in the afternoon, and to keep it to roughly 20-30 minutes, to exercise before 2 p.m. if possible, to spend time in natural light, especially exposure in the morning to bright light, sunlight is a really good idea. Try to avoid caffeine, nicotine, and alcohol use close to bedtime. Establish a comfortable sleep environment and establish a calming nighttime routine. And it's also important to be social in order to sleep. So during the pandemic, individuals who reported greater social participation and sense of belonging had better subjective sleep quality. And this was even by attending things over Zoom or interacting with people over FaceTime. Trying to not feel lonely may improve sleep quality, and being social diminishes stress and improves sleep. A quick note about over-the-counter sleep aids, avoid them. That's the quick message. So antihistamines have a negative side effect in older adults and should be avoided as a sleep aid. Melatonin is thought not to have any side effects and should improve sleep efficiency, but has not been shown to be successful in necessarily reducing insomnia and Alzheimer's disease, but this could be due to circadian changes. Nearly every talk I give, I'm asked about the effects of marijuana and CBD as a suitable treatment for sleep. And the take home again is it's not recommended at this time, certainly not marijuana, and the research is very unclear about CBD and definitely needs further investigation. Caregiving through the night. Caregivers have lower sleep duration, so they sleep approximately 2.5 to 3.5 hours less per week. As I mentioned earlier, sleep helps mood and emotions. It reduces stress and anxiety, can reduce depression, helps regulate emotions, helps in reading emotions, helps in risk assessment, helps in judgment and negotiating. And sleep helps overall health, the immune system, our metabolic system, and our neural health. So how can a caregiver sleep? The try-tos. Try to reduce the likelihood of unchecked sleep disorders for both you and your loved one, and talk to your doctor about medication schedules for both you and your loved one. Try to maintain a stable sleep pattern. So try to maintain your bedtime and your final rise time. Try to exercise or get some daylight in the morning. Try to reduce your level of alertness during the night. So some people use a patient bed monitor or door monitor, or set an alarm if needed for nighttime care. Try to follow the general sleep hygiene guidelines as best you can, and continue to be social, including attending groups like this. So this just today is helping your sleep pattern. And of course, sleep hygiene, unfortunately, for those with neurodegenerative disease, often is not sufficient to actually offset the sleep issues, but they can help ease some. This is our sleep group. So if you do reach out to us, you may be interacting with any of the above. And this is my last slide. I just really want to thank you for listening and participating today. And I also want to thank all the participants and their families that have helped us through all of our research. I'm eternally grateful, as is our research team. And thank you for your time.
Hi again, everyone. It's me, your faceless voice over here, Jessica Shore. You all will see my face later, but hey, Dr. Walsh, thank you for sharing such wonderful information. I mean, so comprehensive to the point where almost every question that we were getting in that I was going to ask you, you went ahead and answered. So let's see, and you sort of touched on this when you talked about napping and how much to limit naps and sort of what time of day to limit your naps to. But you spoke a lot about the tendency for increased daytime somnolence. But somebody had asked if dozing in a chair counts as towards the total sleep during the day for somebody.
Yeah, so dozing in a chair is always so hard, but yes, it counts as a nap. And it does count towards the total sleep someone is getting in a 24-hour period. And especially what's very disruptive sometimes for individuals is, in order to get a full night's sleep, or the best sleep possible when they actually get into bed, is to try to reduce the dozing in front of the TV right before bed. And so that means, if possible, to get up before you normally doze off in your chair and to actually go get into bed, so that you're hitting that dozing period in bed. Since dozing in the chair and then having to wake up and do your bedtime routine to get into bed, which can often be quite effortful for individuals, can really arouse the body system, and you're not meeting your rhythms that are trying to help you go to sleep.
Yeah, that's great advice. Thank you. So we've also gotten a number of questions about medications, over-the-counter medications as well as prescribed medications. And again, I know that you touched on that a bit, but a few people have shared with us that sort of the first line of treatment their neurologist had suggested is melatonin. Mm-hmm. And sometimes that can be helpful for some people, but a lot of people have shared that it really didn't do that much, or maybe wasn't something that helped for a long time. And if you could speak to melatonin. And then we also had somebody who asked about trazodone and how safe or effective that is for this patient population.
Yeah, these are great questions. I stress that I'm a PhD, not an MD, and not a pharmacist. So do talk to your doctors about this. But melatonin is safe. It can be very effective in helping some people. At times, and normally the recommendation is to take it 30 minutes before you want to go to bed. Trying to find the right timing for some individuals is quite challenging. So for some individuals, and we don't understand why, the best time for them to take it is in the morning, which is completely at odds with when you should be taking it. And that seems to have the best effects. Combining melatonin with exposure to bright light in the morning. So again, daylight, if you're in an area where there's very little daylight, having one of those internal sun lamps or mood related lamps really can help getting that exposure in the morning. And so some studies have found that it's only with those pairing together that melatonin can be effective. Melatonin can be helpful at times in helping to reduce the occurrence of REM sleep behavior disorder, but that is not across the board. So I think it is a good place to start. It has no real side effects. And so that's why many neurologists like to try and start with that. And sometimes it's melatonin plus something is pretty effective. Trazodone, I know in our clinic is often prescribed. And I think that it is overall, from what my PhD understanding is that it is a relatively safe medication to try. In some individuals, it is very effective. However, we don't think, because of the nuclei being affected, that it is most likely the best treatment for all individuals. And that's why we're trying to do this remote clinical study where we're saying, well, these are the typical medications given, or these are within similar groups, and let's try something else to actually, instead of trying to turn sleep on, we need to actually help wake turn off. And it feels like they should go together, but they're actually working on different systems. And what most likely will be the way forward in the future for sleep medications is a combination of the sleep wake on and sleep on, wake off, and then vice versa for trying to improve activity during the day. So trazodone overall is safe. In some cohorts, it seems to be exceptionally effective, but more research is really needed, especially for the groups that unfortunately we're talking about today. So trazodone for MSA, CBS, and PSP may or may not be effective.
Okay, thank you. Oh, I have so many. There's a lot more questions on different medications that I know we don't really have time to get into right now. And also some of them are kind of a little bit more individualized. So we will try to answer those as we're able, but just knowing we have about a minute and a half left, I'd like to ask you when someone should get a sleep study if they're living with one of these diagnoses, or perhaps one step before that is, when does someone know that they've developed an abnormal sleep symptom or change that they should report to their neurologist? Because as you sort of alluded to in the very beginning, a lot of people kind of have this assumption, have these misconceptions around sleep and aging, and often don't think about sleep as a symptom of these diseases, so might not always report them to their doctor.
Yeah, it's a great question, and they are underreported and under-asked about, unfortunately. Mm-hmm. Often it's a bed partner or a caregiver that actually notices a lot of the presence of these sleep disorders. And so part of it is, even if you don't have a partner, that if you sleep in a similar environment, to just ask the next day, hey, did you hear me snoring or hold my breath? And trying to be very self-aware. Quite honestly, I think that anybody who has a neurodegenerative disease should have an assessment for sleep disorders. And if you really ask me my opinion, I think that once we hit a set age, just everybody should have a clinical sleep assessment to rule out certain conditions, and especially since some of these are manageable or may suggest the development of a future neurodegenerative disease, that we can say, okay, let's keep an eye out for this, or start specific medications early. So trying to see REM sleep behavior disorder, a lot of times the bed partner may be injured or bruised, or notice if you are trying to self-assess, look to see whether your sheets are twisted at all in the morning. And a lot of times REM sleep behavior disorder may occur only once a month or even once every 6 months. So it's not a every night thing for many people. Insomnia, you can pretty much tell. For periodic limb movements, again, you may see some of your sheets disarrayed, or you may be getting the elbow poke from a bed partner to like, hey, you're waking me up, stop kicking me. And a lot of times people get confused when they're reporting about whether that's REM sleep behavior disorder or periodic limb movements. So really thinking about, was it tied in with a dream? And sleep apnea, trying to think a lot about, am I waking myself up holding my breath, or am I waking up a lot during the night? So they are hard to detect. I would definitely say that people who have a neurodegenerative disease should really try to get assessed if possible.
Yeah, exactly. Thank you. And I guess to add to that quickly too, I know a big question that I would ask people is, do you feel refreshed when you wake up in the morning? Absolutely. Because a lot of times people think they're getting a full night's sleep, but they just don't feel great when they wake up. Still, they feel like they didn't get a full night's sleep. And usually that's kind of a red flag that something might be going on.
Absolutely. And if you ever fall asleep when talking with somebody or at a stoplight or throughout the day, to really think about when you're falling asleep. And there's a number of online screeners that are actually very good. So if you Google it, as much as I don't like saying that, a number will pop up that you can assess how sleepy you are during the day. And that can also be something to report to your doctor, because then that would suggest that you need to do a sleep assessment.
Yeah, that's great. Thank you, Dr. Walsh, for tackling a very important but very complex symptom that can come along with these diagnoses, and for your time today.
Thank you.
And everyone out there, I am excited to pass us along now to our next segment, which is a panel where it's going to be moderated by Kathy Wang, who is a social worker, clinical social workers of UCSF, and she'll be, the panel will be talking about lessons learned throughout the journeys with PSP, CBD, and MSA from the real experts living with them, people diagnosed, and family care partners. So take it away, Kathy and panel.